everyone. Welcome to session 11 of the SCTS Foundation Doctor Academy teaching series. I'm very honoured to introduce tonight's speaker, Mr Mustafa Zakkar, who's Associate Professor and Honorary Consultant Cardiac Surgeon at the University Hospitals Leicester. Tonight he's joined us and taken time out of his busy schedule to talk about infective endocarditis. And without further delay, I hand over to you, Mr Zakkar.
Thank you very much. Thank you very much for inviting me to give this lecture. I think it is very important to be doing this educational series, especially for you young people to see the things that we think about or the things that we think it is important when dealing with different cardiac subjects. I have to say infective endocarditis is a very big and it's a very complicated field. So I'm not going to be able to cover every single thing, but I thought that these are some of the objectives that I would like to convey to you during the presentation. And the presentation is really based on the guidelines, the European guidelines that were published in 2015. And I highly recommend that all of you look at it and read it. It is a fantastic document, okay? So I think for anything you want to do in cardiac surgery, you need to know your anatomy very well. Okay, and I'm not talking about very minute details, but there are some important things that you need to know. Okay, one of the most important things you need to know before doing any valve-related surgery is really not only the valve, but the relation between the valves as a structure of the heart. Okay, so as you can see here, this is very important when we are dealing with the aortic or the mitral valve, because really the aortic and the mitral valve are almost connected to each other, and they are just separated with what we call the fibrous body or the fibrous trigone. So if you have an infection affecting one of these valves, it may extend to the other valve. And it gets more complicated in cases where you have infection in both of them and extending to this fibrous body, extending to the trigone, or what we call continuity. You need to understand the anatomy, you need to understand how to deal with it, because most of the time we're going to end up removing the aortic, removing the mitral, and you have to remove as well this kind of fibrous body and reconstruct the two valves on each other. Okay, the same thing is between the left and right, between the tricuspid and the mitral, for example. Also, we don't have a direct connection between the mitral and the tricuspid, but working on one valve is definitely going to affect the anatomy and the structure of the other. And sometimes if you have a ASD, for example, you may have an infection extending from one side to the other. So this is extremely important to know, okay? Now, the other important anatomy thing you need to be fully aware of is the conduction system, the electricity on the heart, okay? Especially when we are dealing with endocarditis, extended infection, and you're going to end up doing a lot of debridement, you're going to remove infected tissue. So you need to know what these infected tissue going to include. Are you going to give the patient a bundle branch block? Are you going to give the patient a complete heart block? This is very essential, especially when you are consenting and talking to the patient. And we all underestimate how close the structure, like the aortic valve is just really next to the bundle of hairs. When you are working at the commissure between the nun and the right, you have basically the fibrillar septum, and it is just there. And the same thing when you are operating on the mitral or the tricuspid, so you are just next to the AV node. So it is essential to understand these main structures, okay? Next, and I find these two images very important. This is the first image. This is the aorta. And it just shows you how the aorta is very close to other structures. It is just next to the left atrium. It's just next to the right atrium and to the ventricle, to the mitral. And this means really that any infection, any abscess can fistulate, can rupture to any of these cavities. And we see that on many occasions. And I highly recommend that all of you guys, you need to know this image by heart, okay? So in the middle, you have the aortic valve. These are the three cusps, the right, the left, and the nun. And it just shows you all these different structure around it. So the aortic valve is not only a valve in a tube, it's surrounded by important structures. And we see a lot of time, a infection in the non-coronary cusp that has fistulated, and you have basically a big hole extending to the right atrium. We see rupture to the LVO, to the pericardial cavity, to the RVOT. So to be able to deal with these, endocarditis is not only taking a valve and putting a new one, as you will see now, it's more. You need to take all the infected tissue. You need to be able to know if you open a cavity, how to close it, what cavity you are dealing with, what's the consequences. So I highly recommend that these 4 images need to be in your brain for any valve-related surgery. Now, I thought I will start by showing you some examples of some of the cases, and these are 3 cases that I dealt with since the beginning of the year, okay? So this is a simple starting one. So this is a 36 years old. He had no past medical history, and he presented to the hospital with heart failure and pyrexia, okay? And in this view, and this is basically a long axis view of the aortic valve, I hope that you can appreciate this floating kind of structure that is going to the LV cavity and out from the cusp of the valve. And this is a typical vegetation. Now, it's very interesting, and this is where it is important to know, again, your echo images. You're not expected to be an expert in echo, but there are some images that are very important. So if I stop this long axis and I take you to the short axis of the same one, you can see this structure floating in and out. And this is bicuspid valve. However, it is extremely important to kind of realize that you have a much bigger problem here, all right? So you can see that actually the 2 leaflet has dehiscent, and it is on my right hand. You can see this cavity, and this is actually an abscess cavity. So when I took the patient to theater for operation, he had a major big abscess cavity that was extending to the right atrium. So this highlights that you need to look at your images. You need to understand this basic of echo, because before we take a patient to theater, we need to kind of plan what we're gonna do. As I said, endocarditis, it's not just opening and closing and taking a valve. It's more complicated, okay? I will take you to second one. Second one is probably a little bit more straightforward. So this is a 45 years old. Again, he had no past medical history. He presented with heart failure. He had multiple infarct affecting his spleen and his kidney. And this is his echo. And again, straightforward, you can see this massive, big mass that is actually sitting in his mitral valve. So it's kind of almost completely blocking the mitral. And you can see the degree of mitral regurgitation he's having. So this gentleman had a huge vegetation on his mitral, and it was actually extending into his LV cavity. So he had an abscess involving the LV cavity. So again, just by seeing this, you're gonna appreciate it's big. It's not gonna be simple and easy. And you can see the close proximity here between the aortic and the mitral. Third example, and this is a sad one, unfortunately, okay? So we looked at the aortic, we looked at the mitral, and by default, this is really the third valve that we look at. So this is a short axis view. In the middle, that valve that's opening and closing is the aortic valve. You see all these kind of big, lumpy, horrible tissue on the outside of it. This is actually his tricuspid valve. So his tricuspid valve has gone completely, and it's being replaced by this horrible, horrible vegetation involving the tricuspid. So he actually an IVDU. He came to the hospital. He was feeling unwell. They did the echo for him, referred him to us. We accepted him immediately. Between referring him at 1 in the morning and him arriving to us at 2 in the morning on the way to the hospital, he peri-arrested. He was intubated in the ambulance, and he arrived to us on 36 of NORAD, 6 of basal, 6 of adrenaline. His RV was gone by then. So unfortunately, he wasn't suitable for any surgery, and he ended up palliation. But again, it shows you that this is the point I want to keep emphasizing. Endocarditis, it's not just we're going to take a valve and put a new valve. It is more complicated. And these are the things that we are seeing routinely in our practice. So to move on, we'll start with what's the definition? What do we mean when we talk about endocarditis? It's simple. It is basically a bacterial infection, or not bacterial, microbial infection that is affecting the endocardial surface of the heart. As simple as that, okay? We know commonly it sits on the valve, but not necessarily. You can see endocarditis in the chordae of the mitral. You can see it if you have a septal defect, etc., etc. So how we can classify it, what kind of system we can use. And again, there are many of them. You can use whatever you want. Some people talk about acute and subacute or chronic, etc. Some people will classify it staph, strep, hack. It depends on the organism. And some people will talk about this as a native valve or prosthetic valve. But the guidelines actually talk about something different. They divide them into a left and right-sided. And I will explain to you when we go through the presentation why it is important, in my view, to look at it as a left-sided, which is mainly mitral and aortic, and right-sided, which is tricuspid. Extremely, extremely rare to see any pulmonary, if any. And again, most of the time, you don't need to do much of treatment for the pulmonary except antibiotics. So to move on, just a little bit about how the view and how basically endocarditis changed over years. We are seeing a lot of endocarditis now. And I think an element of it is probably to do with COVID and to do with a period of lockdown. A lot of patients did not even go for medical checks. They had a little bit of problems. They did not, seek medical advice. And now we are seeing them coming with more complex cases of endocarditis. Again, it increased because people are living longer and patients have a lot of comorbidities now. And a lot of these patients admitted for something different, urological intervention, whatever intervention, they can develop an endocarditis as a consequences of other diseases that they have. It is estimated probably in the US and Western Europe that it is around 1.7 up to 6 cases per 100,000 person year. And it is roughly male to female, maybe male a little bit more. And the main age now is getting a little bit older. So we are seeing older patients presented with endocarditis compared to, let's say, 10 years ago. It is interesting that when we talk about IVDU, drug abuser, the incidence of endocarditis is much, much higher. And it's shocking that it is almost 2,000 per 100,000 person year. And the chances of an IVDU to get an endocarditis will get even much higher if they have any valvular heart disease. Why is that? It's simple for me as a cardiac surgeon. I understand that for you to have an endocarditis, you will need to have 3 things really, okay? You need to have an abnormal valve. We know that if your valve is pristine, normal, no issue with it, it's almost impossible that you're gonna have endocarditis because we have the endothelium. The endothelium on the valve leaflet are very good in producing all these molecules that work as antithrombotic, anticoagulant, and they are very protective. So you need to have a degree of damage, maybe related to having regurgitation, maybe related to having abnormal blood flow if it's a bicuspid valve or stenosis, etc. Okay? So this is the first thing, an abnormal valve service. And then you need, after that, platelet and fibrin to come and sit on the valve. And this is simple. If you have a damaged surface, this means that platelet and fibrin will get activated on the damaged area in an attempt to repair it, kind of. And this is something very known in inflammation and in the field of vascular biology. So these fibrin platelet will come and sit on the abnormal surface tissue. And you end up with this kind of lump and area, which it's called basically non-bacterial thrombotic vegetation. And obviously, the third thing that you will need after that is bacteria, bacteremia. So you need an infection to come through the system. So infection will come find this abnormal area, which is basically thrombotic vegetation. It will sit in it, more fibrin will form on it. You will get more leukocyte, more neutrophil coming and forming on top of it. And you end up with these big mature vegetation that we usually see when the patient presents to us. So where does these bacteremia come from? It's simple. They come basically, we see that in patients who have, let's say, ascites, cellulitis. So they have a systemic infection where bacteria can go to the circulation. It can come from the outside. IVDU is an example where injection was from the skin or dirty needles. We see that in patient urology, catheter, patient in ITU, CVP. So anywhere where you can introduce infection from the outside to the inside. Again, commonly, if you have a mucosal surface that get traumatized, get infected, and this is where we see in dental infection or in patients who are having GI or GU operations. We know 2 things. we know that lesions that need to have a high degree of turbulence for bacteria to come and sit on it. So it's to do with the way the blood flow. If you have a blood that's flowing in a normal way, which we call a laminar flow, non-turbulent flow, the force of the flow is protective. So you're not going to end up with deposition of bacteria and microbial stuff. But if the flow is turbulence, you will have this circulation, and this will allow this bacteria to have time to sit on the surface and start developing this infection. And this is what you see when you have stenosis, for example, in the aortic, when you have a regurgitation as well, because you have these kind of disturbances or oscillatory flow. You have it when you have small VSDs. And you need to have a large surface area. So small, tiny areas, you're not going to develop infection. So you need large surface area. And again, it's to do with the way the blood flow and whether it's laminar or disturbed oscillatory flow. Now, what are the most common site of infection? We know that the heart valves are the most common site. We know that the aortic valves are usually more common than mitral valve. Usually, this is a very common question you get asked every time, and you're gonna get at some point asked in your exams, where does it sit? We know that the aortic vegetation sits usually in the ventricular aspect. All the cusp, one way or the other, will get affected. It's very rare to see it very localized to one cusp. And even if you can't see it, you're gonna have kind of micro depositions there. The valve can be destroyed, you can have a perforation, you can end up with regurgitation, and you can develop these root abscesses. And these are horrible to deal with because, as I said, they can fistulate, they can rupture. So it's not an easy thing to do. For the mitral valve, you're gonna end up most of the time with a perforation, you can, or a rupture of the chordae, and as a consequences of that, you're gonna have leak. So it's gonna be a mitral regurgitation. Rarely, as I showed you in the echo from example 2, you're going to have extension to the annulus or extension to the trigone, extension to the aortic, and these become more complex because you need to reconstruct the annulus, and usually it is a big operation to do. The tricuspid, we see it mainly in the IVDU. Most of the time it is the leaflet gun, and most of the time we end up kind of replacing it. Very rarely you repair it, but it's not unheard of. As I said, the pulmonary is very rare to get infection. Again, as I said, it's not only heart valves, it can affect everything. So if you have a prostatic valve, it can affect the prostatic valve. It can affect if you have ICD lead or you have permanent pacemaker lead, they can get infected and you can end up with big, massive vegetation on them. So how do these patients present? We all know that most of the time they're going to present with fever, but it may not be everyone, but most of the patient will have a high temperature at some point. 30% of these patients, they will have some embolic event. Usually you see embolic to the lung, to the spleen, to the kidney, and even to the brain. And that's why it is important when someone presents with embolic event to always make sure that you examine them systematically, listen to the heart, have a very low threshold to do an echo for these patients, especially if it's a young patient and there's no reason for them to have an embolic event. Always think that it is an endocarditis or it can be endocarditis. With more chronic kind of infection, you can see night sweat, malaise, weight loss, anorexia, etc. And as I said, important, listen to the heart. You're gonna hear a new murmur, or you're gonna have a regurgitation murmur in the setting of, let's say, tricuspid or mitral, which the patient did not have before. Blood tests, the usual stuff. You can basically, patient will come a bit unwell, not very high temperature, but they will have high white cell count. They will have basically high CRP. They can become anemic, as you know, with chronic diseases or acute infection, or they can present with glomerulonephritis, and it is one of these kind of, they call it immunological kind of responses to having an endocarditis. For patients who have a right-sided endocarditis, usually it's very rare. And again, it is from anatomy. Why would you develop a systematic kind of or peripheral embolic phenomena if you have a right-sided, unless you have a communication between the left and the right, and you need to have the shunt from the right to the left. So it's very rare for someone who has a tricuspid endocarditis to end up with a kidney infarct or a spleen infarct. But usually or actually most of the time you will see that they were gonna have at least a small area of either a pulmonary infarct or a pulmonary abscess. So it's very common because, again, it goes through the RV, and from the RV, it goes to the PA. So it's very common for this embolic event to affect the lungs. This is, again, one of the things that is very common for the exam, and you get asked about them, these vascular immunological phenomena. We see them these days, strangely, because, as I said, patients can present late. I mean, I have to say, the last time I've seen a Ross spot was probably, I don't know, 15, 20 years ago. But definitely you see splinter hemorrhages, you see the ossular node, and you see the Janeway lesions. So these are things to look at, and it's very interesting when you see them. It kind of confirms your diagnosis in a way. Now, we all hopefully know about how we diagnose or what the criteria that we need. So we need the modified Duke criteria. And the modified Duke criteria divide endocarditis into three. You either have endocarditis, definite endocarditis, visible endocarditis, or rejected, which means you don't have endocarditis. For definite endocarditis, you need to have basically an evidence of the endocarditis, and it can basically be that a microorganism being demonstrated from the vegetation or from the abscess. So you need to have this kind of confirmation from the valve, from the tissue itself, all right? If not, you're gonna have to go through the clinical criteria, and it tells you that you will need to have either 2 major, 1 major, 3 minor, or the whole 5 minor criteria. And again, for the possible 1 major, 1 minor, or 3 minors. So these are the major criteria. And again, they are very important for you to know because they are a common kind of exam question. In reality, most of the time, these patients, they present to cardiac unit already been diagnosed, probably either early in their antibiotic treatment or late after the antibiotic treatment or acutely. So most of the time, the diagnosis is made for you. But for the sake of the exam, for the sake of getting your FRCS, etc., you will need to know that these are very common questions in the exam, okay? Now, blood cultures, it goes without saying, you know, it is, if you have blood culture positive, you're gonna basically, your chances of having endocarditis is very high, all right? And again, the criteria gives you these kind of guidelines about how many you need, something like 3 of them, and you need to be taking 30-minute in interval. Don't take them from a central line because the chances of having infection or contamination in the central line are higher. So usually take them from peripheral, clean stab, and always, it goes without saying, you need to send it for aerobic and anaerobic. I think the important message that you will need to take from this is this one really, okay? Always culture before you start antibiotic. If you suspect endocarditis, if you suspect anything, send the blood culture before you start antibiotic. And this is because we see sometimes patients who are presenting with a culture negative endocarditis, okay? And it can be most commonly because already the antibiotic started, so the bacteria is kind of dead and you can't culture it, all right? But not all the time, because some of the times it can be because of the hack, for example, or the fungi, etc. And when you go through this pathway of culture negatives, this becomes a bit more complicated for a cardiac surgeon. And we're not expected to know everything about it. What you are expected is basically to liaise very closely with the microbiologist and be advised by the microbiologist about what they do, because they can either do a PCR or they can do kind of different special kind of serology, different kind of antibody of whatever IgG that they do, and it will aid for the diagnosis. But you need to know a little bit about it differently for the exam itself, okay? Now, the guidelines give you this very kind of nice diagram about how to do and what to do in terms of identifying, doing the blood culture. So again, have a look at it. It is important to have an overview about this. But usually, my advice is always early liaison with the microbiologist. Never manage these patients as a cardiac surgeon or cardiac surgery only. Okay, never. These old days are gone. We work in a multidisciplinary system, and I will go through that a little bit in more details later. Okay, so these are the blood culture. Now, imaging. It goes without saying, it's very simple. Echo. It is the technique of choice. You know, it can show you the vegetation, it show you the function of the heart, it show you extension like abscesses, cavities, whatever. And usually transthoracic is the way to go. It is very quick. It can be done even on the ward. Any good cardiology registrar should be able to do it. And it is very excellent in specificity, okay? Occasionally when we can't or we suspect it is maybe not, we're not sure, all the signs saying it is endocarditis, but we can't see a vegetation or we want more detail, this is where we go for TOE. Okay, and TOE is definitely more invasive. You're going to put a tube through the gullet of the patient. It's very uncomfortable, but I think it is very important. And to be honest with you, for my practice, I usually ask for TOE for most of these patients, and you will be surprised with the things that you find that a straightforward transthoracic echo will not be able to pick up for you. Okay, so again, the guidelines give you these kind of diagrams where they say, okay, do a transthoracic. If you don't find, then go through the TOE pathway, right? But I think the table is very important because it summarizes the important things that transthoracic or a TOE can tell you. You're going to see vegetation. You're going to see abscesses, as I showed you that big cavity in example 1. You're going to see pseudoaneurysm, which pseudoaneurysm, we know it's a ruptured contained ruptured, you see it in the aortic, or you see it sometimes even if you have a bad infection in the mitral. You're going to see leaflet perforation, you're going to have the fistulation, or if you are talking about prosthetic valve, you're going to see paravalvular leak, or you're going to see the valve rocking. So these are all signs of dehiscence, and these are really the information that an echo will be able to give you. Again, I have very low threshold in any patient who have aortic endocarditis to do a CT scan for them, right? I think it is very essential, especially in this age, to get all the information that you need to have with you before you are taking a patient to theater. Because again, as I said, it's not a matter of taking a valve and putting a valve. You need to be able to do proper debridement. You need to know what are you facing, because this will affect the way you're going to manage it. How are you going to deal with this defect? Are you going to deal with it by a patch, by a homograph, by whatever? So get all the information. It is very important. Again, when we are talking about aortic, doing a CT scan can tell you about the size of the annulus, can tell you about the size of the root, can tell you about the ascending aorta. So it's very important when you're consenting a patient or planning an operation. Are you going to do a valve only? Are you going to have to replace the root? Are you going to have to replace the ascending aorta? So these are very important information. As I said about the right-sided and the pulmonary abscesses, pulmonary emboli, again, CT scan give you this information. It's very important in the perioperative management, especially for ITU, to know what kind of disasters they're going to be dealing with after surgery in terms of ventilation. And again, you know, for prosthetic, always do it, because it is very good to know whether you have vegetation. They can give you reconstruction details about the abscess, about the dehiscence, about which area is dehiscent as well. In young patient, and even these days, even in a little bit older patient, when they do the CT scan, they will be able to look at the coronary. So they will do a cardiac gated CT, and they can look at the coronaries for you. And if the coronaries are normal, then you can avoid doing coronary angio, because doing coronary angio, a lot of cardiologists will be a bit hesitant if you have a root abscess or you have a big vegetation to do an angio for you, because the chances of embolic event will be much higher. Okay? And this is the final point I wanted to make about the CT scan. Again, you can have other modalities, MRI, PET scan. MRI is sensitive. People think about doing MRI if you are suspecting brain embolic event. So it's not to look at the heart structure itself, it's to look at other area where you suspect an emboli. PET scan, it has a room as per the guidelines. It's very rare these days we do a PET scan. In all honesty, I don't remember when was the last time where I've seen a PET scan. But again, it is with these strange cases where you don't know whether there's an active infection or not. If you do the FDG PET scan, it can give you more kind of uptake in the area where you have leukocytosis inflammation. So it indicates to you that, okay, there may be an active infection happening in that area. This is one of the things that the guidelines emphasizes about. Patients need to be assessed as soon as they are admitted. And the rationale behind that is because, first of all, mortality is very high. Around 30% of the patient will die during hospital stay. And almost half of the patients who are admitted with endocarditis, they will have cardiac surgery during the admission itself, okay? So it's very important as soon as the patient comes to be fully assessed. And what I mean assessed, we need to know exactly about their comorbidities. We need to know exactly about frailty scores. We need to know about, okay, what they can do, what they used to do before, what they are doing now. We need to know about their kidney function. We need to know about their brain functionality. Is there any blood being done? What kind of organisms we are dealing with? And we need to know in details what the echo finding. Is there anything else that we need to do in terms of imaging and investigation? So you need to have all this information. And this is really your role as a junior doctors, because you are the first line of seeing these patients. And it makes a huge difference when you come to see the patient in the morning or at night to have one of you guys with all this information rather than checking this, was this done, was this not done. It delays things because the quicker we identify who need an operation, emergency, urgent, the more chances of saving them. So getting all this information important, because again, you're going to sit and talk to the patient. You're going to quote the patient some kind of risk. You're going to do your Euro score. But you need to have all this information for you to go and sit with the patient and calculate the Euro score. So this is one of the important issues that you guys need to be in the front line of doing. Now, let's start by what kind of treatment, how can we manage this endocarditis, okay? It goes without saying that antibiotics, and antibiotics is not something that me as a cardiac surgeon or you as a cardiac surgical team decide. I don't think this should happen anymore. It's very, very, very specific. As soon as we admit a patient with endocarditis, we get the microbiologist involved immediately. We do an early MDT. You don't need to have a big fancy MDT with 100 people. All you need is 1-2 cardiac surgeon, 1 or 2 cardiologists, and a microbiologist, imaging technician. And this is something that the society been pushing very hard for. Endocarditis MDT. You can start small local and then you go and do regional, but don't make a decision as one person about these patients. These patients are very complicated. And once you get bitten once, twice, you will learn it the hard way. And even if you don't get bitten, you know, it is very important. We don't treat patients as they belong to one person and I am the God, I am the one who makes decisions. No, that does not happen anymore. A decision about these complex patients need to be based on a discussion with a lot of people. We know that antibiotic is essential because it's going to eradicate the infections that you have. Okay, but surgery, it will deal with the remaining infective material or the complication like abscesses or fistula. Okay. Now, the guidelines are very clear. For a native valve endocarditis, usually 2 weeks up to 6 weeks, depending on the bacteria or the causing factor. But for prosthetic valve, it should be longer. So it should be at least 6 weeks on antibiotic. And usually we are very much guided by our microbiologists. We do whatever our microbiologists tell us. These are very 2 important points that I want to make. That one of them is that the duration of treatment is based on the first day of effective antibiotic therapy, okay? Not on the day of surgery. So it's not like, oh, I did the operation today, this means that I will start or continue with the antibiotic for 2 weeks or 6 weeks. No, it does not. Your antibiotic regime starts maybe 10 days before surgery or maybe 2 weeks before surgery. And this is where the duration of treatment, okay? And again, this is the second important point, that a full new course should be started if when we send the valve or when we send the tissue comes back positive, because this means that you still have an active infection, okay? And this is where you say, okay, now a new course gonna start. And our microbiologists in our department are very good with these. They will come and say, okay, listen, we found this, start the course from beginning or adjust your antibiotic, but do it as a new course. So know about this, but liaise with cardiologists and with the microbiologist. Now surgery, and this is the thing we contribute usually to the patient, okay? The principle of surgery in endocarditis is extremely simple to talk about. It is difficult in reality, okay? Surgery, as I told you, around 50% gonna need it while they are in hospital, because one of so many reasons that I will tell you about in a minute, okay? even when you decide to operate on this patient, as I said before, please involve others. Okay? Go and speak to one of your colleagues. Say, oh, I have this horrible case. I'm going to do this. Discuss it. We discuss our cases sometimes in our TAVI MDT, sometimes in our aortic, in our mitral MDT. So we discuss it. You'll have cardiologists, you'll have a lot of people who can contribute. If you are missing a test, they will arrange it. They will help you. Always get the heart team. And the heart team concept is the focus for all the guidelines from the 2015 for the endocarditis. The European guidelines always talks about the heart team. Okay. Now, we have reasons why we need to operate early on these patients, and sometimes we can wait until the antibiotic course is finished. In reality, the reason to operate on them early is either to, if they have progressive heart failure, or to prevent them from having that, or if they have an embolic event with big vegetation, or if there's a structural damage. But keep in mind, operating on someone acutely with infection, edema, horrible tissue is not going to be easy. It's going to be associated with a huge amount of risk and mortality. So if you don't have to do it acutely, don't wait until the antibiotic. And one of the concepts that one of my old mentors used to say, he used to bathe them. So he used to bathe them in antibiotic until they are ready to have their operation. So, and again, this is where talking to more experienced senior colleagues, cardiologists, microbiologists will help you make the decision in terms of, shall I do it now? Shall I do it in 5 days, or shall I give them 2 weeks for the antibiotics? Okay. Now, these are really the guideline indication for surgery. And again, when I started talking to you earlier, I talked about the left and the right side. And this is the reason, because the guidelines talk to you about left and right-sided indication. So as I said, either they are acute heart failure, or to prevent them from having heart failure, uncontrolled infection, or prevention from embolic. And they talk about the sizes of the vegetation, whether they have an embolic event or not. You need to know these by heart. There's no question about it, okay? Now, they give you some definition about what uncontrolled infection is and what about persisting infection is. And again, you definitely need to know that. You need to know whether your patient is not responding to antibiotic, and so they have persisting infection, or they have uncontrolled infection, which means that now they are developing an abscess, they are start developing a new bundle branch block that they did not have. So you need to know these definition by heart. Okay, this table is important to know. Okay, so now what happens if a patient present to you and they already have a brain infarct or brain hemorrhage? So they already had a neurological complication. This is one of the trickiest areas in dealing with these patients. Are you going to operate on them if they are intubated, ventilated, and they had an embolic event? Are you going to operate on them? We don't know, are they going to survive or not? You know, what's the consequences? We know if they had a hemorrhage and you put them on the bypass machine, they're going to bleed more. So there are different things to consider in the setting of a neurological complication, okay? And the guidelines give you a lot of details about it in terms whether it is basically an hemorrhage or it's not a hemorrhage. And what do you do if you have a hemorrhage or a coma or a lot of comorbidities, or if you don't have it? So it gives you a lot of details. And I think you need to know that. It's very important, all right? Now, what do we do? As I said to you, talking about the surgery is very simple. You need to do really 2 things. You need to remove all the infected tissue, and then whatever defect you are left with, whatever thing is missing, you need to reconstruct it. So if you've taken the annulus, you need to reconstruct the annulus. If you've taken the LVOT, you need to reconstruct the LVOT. If you remove the LA with the continuity, the aortoventricular continuity, you need to do it. It's easy to say, oh, you need to do that. It's not in practice. You need a lot of experience. You need people to be with you, support you, especially at the early stages of your career. And a lot of centers with these complex cases, they will have 2 surgeons operating together. We used to have in one of the places where I worked 2 teams. One team will come and take all the infected tissue, leave, and the other team will come and do the reconstruction. So you're not biased or not limited by what you are going to do later, okay? Now, we know that if you repair or replace valve, it's fine. You know, you can do whatever you want, whatever you're comfortable with, whatever is basically good for the patient, all right? You can use for your valve replacement mechanical, prosthetic, bioprosthesis, homograft, freestyle, whatever you want, okay? We know that if you have a healed, let's say, an infective endocarditis with, let's say, a perforation or small vegetation on the mitral, the tricuspid, it's better if you repair it. You can basically resect it and do a patch, all right? And you can even do that if you have an aortic perforation and you know how to do an aortic repair, all right? Now, this is very important, all right? And this is, again, one of the most common questions in the exam. There is no evidence that mortality is affected if you use mechanical or biological prosthesis. The chances of reinfection of mechanical or biological are really the same in the long run. So it does not matter, neither one of them carries more protection, okay? People talk about homograft or freestyle being better. But the problem with these, they get calcified, they get a lot of deterioration within 5 years or so. So you are exposing yourself or the patient really to redo a more complex operation. All right? Don't put a lot of Teflon, don't put a lot of pleasure, don't put a lot of things that you don't need to, because any foreign body is going to carry a risk of a later infection. So keep all these foreign bodies to minimum. All right? Now, when you have an abscess, you need to debride it. You need to debride all the tissues. There's no question about it, okay? And the way I do it, I very rarely use a homograft or freestyle, okay? I tend to do pericardial patches for a lot of these patients. You find the cavity, you clean it, you debride it. I usually put big pericardial patches. If it is LVOT aortic, I take it all the way out to my incision line. You can do that. So small abscesses, you can close them directly, very rarely you see it, but it can be done. And the larger cavity, if you put the patch, again, people recommend that you should basically drain it to the pericardium or circulation. Again, it depends on it is how much infected. Is there an active infection there? You think that you'd debride it all. But the main two important point I want to make is remove all the infection tissue and then worry about the reconstruction. Don't do it alone. Always, it's nice to get someone to be with you, even if you are experienced. Again, I can't emphasize it enough. Total excision, total excision. There's no question about it, okay? Now, we know that these operations are, as I said, not easy in reality. They are associated with a lot of complications. The hospital mortality is up to 20%. They're gonna bleed like hell. You know, you're gonna maybe end up taking them to theater once or twice, especially if you're doing a complex endocarditis. They're gonna stay in ITU for a lot of time. They may have stroke, and they may end up with permanent pacemakers. All right? And they can have one of two things, and this is very important. 2 points you need to remember. They're gonna have either relapse and or reinfection. You need to know what's the difference between that. Relapse, it is the same microorganism. Reinfection, it's a different microorganism. Relapse, usually you're gonna have relapse because you did not do a good job probably in the first time, so you did not debride it, or the antibiotic treatment was not adequate. And that's where you need to be very radical with the debridement if you are operating on this patient. Now, to talk a little bit about the right-sided endocarditis. Right-sided endocarditis, up to 10% of the cases. The mortality is 7%. As I told you, it's usually IVD used. Most of the time, they will have HIV or at least seropositive. It can occur endocarditis on the right side if you have an ICD, infected ICD, or infected pacemaker, or prolonged central time. And as I said, it is almost all the time the tricuspid, but it can extend to the left side. They present either with fever, as I said, pulmonary emboli, or if they have a shunt, if they have a connection between the left and side, they may end up basically with a left-sided. If you have someone with a systematic embolic event and a right-sided endocarditis, look for the left-sided endocarditis. All right. Heart failure is rare, but they're gonna have a lot of pulmonary complication. Pulmonary complication may lead to pulmonary hypertension, and this in turn may lead to heart failure. Treatment. Definitely antibiotic is the main treatment for right-sided infective endocarditis. Now, surgery, the guidelines say to you, should generally be avoided in IVDU with right-sided, okay? So they give you a class 2A, and they tell you some of the things where you can operate on them. I think the most important one, if you have a tricuspid big vegetation more than 2, and an embolic event if you have a heart failure, or if you're not able to eradicate. So I think don't just operate on every right-sided, find a good indication. Otherwise, antibiotic is the main treatment for these patients. Remember, these patients, most of the time they will go out, they will start taking drugs again, and they will come back to you within 6 months, 1 year, and you have to end up most of the time doing a horrible redo. So again, counseling the patient, being very frank and honest with them that this is one go and one go only. And you're not gonna go back again, because usually if you go back again, it's basically you're taking them to the morgue. Most of the time it is extremely difficult to operate again on them. Just quick thing about prosthetic valve endocarditis. This is the most horrible thing you can deal with. It can happen in up to 30% of the cases. And yeah, it can occur in patients with prostheses. As I said, it does not matter whether the patient had a mechanical prosthesis or a bioprosthesis, the chances of infection are the same. We know this is the two things about early, within 1 year of surgery, and late after 1 year. We know basically that they present usually a non-specific low fever, a little bit unwell here, a little bit unwell there. They will have a new murmur they did not have before. The valve will start leaking, or they will dehisce, they will have a paravalvular leak on echo, or sometimes it will get obstructed, okay? Now, the early and late are very important, because usually people talk about early prosthetic valve endocarditis, that it is technical related, and late it can be to other causes. Every patient who have prosthesis and they have temperature, you can't tell really why, always consider this endocarditis until proven otherwise. So always treated with high suspicious, and always culture and antibiotic and microbiology involved. Okay. Mortality is double the usual for the native valve. And that's why when they come in, we need to know exactly everything about them, as I told you, in terms of the assessment. These are factors that we know are associated with poor outcome. Older age, staphylococcus is horrible, or fungi, and if you have it early, okay? Usually, as I said, antibiotic is more than 6 weeks with liaison with the microbiologist, and surgery, it is very complicated. It's a redo setting. Always radical debridement, removement of any infected tissue. And I think here homograft has a very important role in the aortic setting, because you can use a mitral leaflet and extend it down to support your repair, stentless, etc. You can do whatever you want really, but again, the principles are the same: radical debridement and removal of all infected tissue. Other areas or other infective endocarditis specific things that I'm not going to talk about, but you can read about it in the guideline, is, as I said to you, ICD, permanent pacemaker, etc. Patient during pregnancy, they can be basically a subclass. They have specific kind of, in terms of what antibiotic, when you can operate on them, how you counsel these patients, okay? And there are kind of non-bacteria associated with cancers, and there are some endocarditis in the congenital heart setting, but these are very specific, and it is rarely for an adult cardiac surgeon to see these kind of things, with the exception, obviously, of the cardiac devices. I think that's about it for me, and if you have any questions, please go ahead.